So we'll start off with a good one right at the top. 30-year-old male presented as a polytrauma after a head-on MVC, was declared a GCS of 10 upon arrival, but then was intubated and sedated per the trauma team, apparently for shortness of breath and difficulty breathing. There's no other supporting information. Here you can see their vitals as well as their extremity exam from the orthopedics at the time. They were noted to be hyperreflexic in all extremities at the time of injury and had a right lower extremity injury. Here you can see their comminuted patella fracture, right lateral talus process fracture. No other injuries on chest x-ray, pelvis, or head CT.
I was going to ask Dr. Hurlbert to comment on those orthopedic injuries, but never mind.
We could get some of the neurosurgery guys. But I didn't put on the head CT to entertain them. So basically the spine exam was unable to attain a complete exam. It was noted that their bulbocavernosus reflex was intact, but they were hyperreflexic on all of their deep tendon reflexes. Obviously the right lower extremity was not tested to full capacity because of the previous injury that was noted. Here we can see, hopefully the CT plays. Yes, it is. There we go. And so I'll kind of let that play through the sagittal. And then I'll just kind of skip forward. Here you can see the representative cuts of the right and left facet joints and the midline sagittal, as well as the midline coronal.
What was the mechanism of injury again?
It was a head-on MVC, and I believe that the patient was an alcohol-intoxicated passenger, unbelted.
That's not good.
They were noted to be GCS of 10 on arrival and were supposedly moving things, but we don't have any documented from the trauma team or the orthopedics at the time. Impression was no fracture, CTA, no arterial injuries at the time.
Fracture dislocation, you gotta stop right there.
Well, it just says subluxation, so.
I mean, so this is a big problem with our radiologists as well. And for a patient like this that's obviously neurologically obtunded, and you said clonus, but gosh, don't go past that CAT scan, because the people in this room really need to look at that and never, ever, ever miss this injury in their lives. Sorry, Jens, I couldn't help.
And so I believe at the time, orthopedics was not yet consulted. The patient was taken to the ICU because they were intubated or sedated. And because of neck swelling, the patient apparently received an emergent MRI. And here you can see, yeah.
So, can anybody point that out? Can anybody point that out? I mean, here's your radiologist. They say it's normal. Is this normal? Come on.
The OC...
Bijan, you and me, we're old guys. We don't get to... Let these young guys talk first.
Oh, okay.
I know you know what that is.
Nathan, condylar gap.
Yeah, come on. The most sensitive indicator of craniocervical dislocation ever is the sagittal CAT scan, parasagittal CAT scan. 1 millimeter difference in the occipital lateral mass to C1, and that's it. It's unstable. Look at that. Look at this gap. This should be sitting right down in here, and there should be a 1 millimeter joint. That's it. End of story. Diagnosis, craniocervical dislocation, high spinal cord injury possible, if not probable, right?
Dr. Chapman, is there any reason to just start doing some calculations? A to B over C to D, all that kind of stuff?
So first of all, the powers ratio was only relevant for anterior, which this is, but that's another subject. Does it even matter if we have anterior or not? Let me ask Dr. Arabi, go back to the neuro exam. So this is nice, it looks pretty complete, but we are in an era of EMRs now. We have everything nicely done. Why do we still have these kind of improvised exams that are kind of handwritten? Shouldn't we have organized Asia templates?
I didn't think that his GCS was 14. Was it 14?
It was supposedly 10 on arrival.
10.
Rounded down.
So 10, how can you have such a very discrete exam? Well, obviously there is partial spinal cord injury.
Yeah.
And that partial spinal cord injury needs at least a GCS of 13 to 15. So I think either you don't want to show me the CT of the head or the CT was normal. So this patient has a spinal cord injury, incomplete spinal cord injury, yes.
Was the patient intubated already?
Yeah, the patient was already
So at the time of this
intubated
exam,
at
the
time
patient
of
was
orthopedic
intubated.
exam, and I don't know how it is at other centers, but the extremity or neurologic exam from a trauma team is somewhat limited, other than saying can move extremities, but then who knows? And then I'm not 100% clear if he was already intubated on arrival or was intubated shortly after arrival, so it's kind of hard to tell.
So I agree with John that that cervical spine is definitely abnormal. I don't commit myself to the right side, but the left side definitely is the occiput C1, C1, C2 is unusual.
Bijan, what about the prevertebral swelling? I know we have an endotracheal tube in here, but do you have any words of advice as a screening thing? Because lateral C-spines are still obtained. When is a prevertebral swelling abnormal?
Well, there's no question that I was waiting for the MRI to see in that region before C4, without an MRI, there is swelling, but I don't want to commit myself.
Was this patient put into a neck collar?
The patient, I don't believe, was in a collar until after orthopedic spine was consulted after the MRI.
So there's nothing there, free-floating head.
I believe that is correct.
All right.
I believe that's the case. I
Why?
could be wrong. They maybe. Well, that's the other thing. So
So they intubated before they had the CT, and he didn't have a C collar on when he came in, unrestrained passenger.
well, supposedly he was moving and awake and alert in. That's what's unclear.
UCLA Harbor. What is UCLA Harbor?
He doesn't qualify for.
In terms of intubation?
Intubation, immobilization, unknown.
So at Harbor UCLA, they're incredibly paranoid. If there's any concern for C-spine injury, even minor disc herniations, they'll consider fiber optic intubation. In this case, I mean, if this was before any specialty consultation, if they were just going by the read, they probably would have intubated routinely. But if there was any concern for spine injury, they would have done a fiber optic probably.
They didn't have the imaging until after they intubated, so they had no idea what his spine looked like. Look, the ET tube is there.
What about Houston? What about Arizona? Intubation, immobilization?
Well, yeah, you got to immobilize this patient first, and then, I mean, yeah, they're going to intubate this patient. I know they would have in Arizona, in Tucson, they would have intubated this patient right away after the patient was immobilized in a C collar, without a doubt.
John, you commented on frustrations with neuroradiology. Do you have regular shared conferences or something where there's kind of an exchange of information?
I don't know. I think the neuroradiologist will call the house staff, but the attendings kind of get left out of the loop, and so we often get left to pick up the pieces. But and my biggest beef will come with the MRI, because then the neuroradiologists go crazy interpreting ligamentous disruption. But in my mind, you have to think of the occipital condyle and the lateral massive C1 almost as a ball and socket, and this is not a ball and socket, right?
I want to make an assumption, Bijan. If this patient had the CT scan first and had been intubated at shock trauma, what would you have asked the immobilization to consist of?
Well, actually, 100% of these patients would go to hard collar, first. Hard collar.
They'd be in hard collar even before they hit the CT scanner up.
They come in with hard collar.
Yeah,
period.
exactly.
Number
Presumed,
two,
yeah.
number two, looking at that occiput C1 and C1, C2 plus that C4, C5, C6 prevertebral swelling, there is no question that there is a major trauma to the neck. And I would assume we have a good number of these patients that at the University of Maryland, they actually arrest and come to the university with cardiorespiratory arrest, because that injury is so dangerous, so dangerous.
We've had the same thing. Yeah, we've had the same thing.
Yes.
At Harborview, he would have had, based on a protocol, but we've missed these many times. We had to change our protocols. That's why I was asking Dr. Hurlburt. We had to put these patients into sandbags with a tape across, because a collar actually distracts these
If
patients.
they're in a collar already, would you take them out to put the yeah.
Yep.
Okay.
Roll under the neck.
It'd be fair, though, to say, Jens, that the really red flag here would be just you would never put this patient in traction, right? Collar, sure, sandbag, sure, but the traction is contraindicated in this patient.
Yeah.
All right, show us the MRI. See,
So, some foreshadowing was already obtained. Here you can see.
so what all is torn here? Nathan, do you want to take a stab at what is torn? What are the relevant structures that are discontinuous?
Well, I mean, you can clearly see the cruciate ligaments torn. I mean, there's no question that TAL is torn. I mean, the joint there at the condyles are torn.
What is that?
The ALL, I mean, that's the extension of the ALL is torn. Tectorial membrane, I'm sorry. PLL, tectorial membrane. I apologize. I don't know, am I missing something? The posterior ligaments are all torn.
I mean, the facet capsule is torn. So
Yeah, the facet capsule at the top and the one, two, I mean,
strongest ligament is the tectorial membrane and the cranial junction. Second strongest, surprise, was the atlantoaxial and the atlanto-occipital joint capsules.
yeah. I mean, those are obviously gone.
Nathan, what direction does the transverse atlantal ligament run?
Well, that's it goes transverse. I'm sorry, I said the wrong thing. Yeah, you don't actually see it in this.
Yeah,
Either
so
of these
in a
slices.
distracting injury, the transverse atlantal ligament
Should be-
probably would be pretty
Yeah, it should be
robust, right?
Yeah.
Yeah. But what are the three small ligaments? Two of them have the same name. So the two ligaments that kind of connect the clivus, are they going to be intact?
I can't remember right now, but I don't think so, no.
Yeah, the apical and the alar ligaments,
thanks.
they're going to be torn for sure. But I think, as Dr. Chapman said,
There might
the
have even
strongest
been a little
ligaments-
flex sign here on the coronal CT. Maybe you can see right
Right there.
over in here. Maybe, I don't know, but
And Nathan, is the transverse ligament torn in this case?
I don't even see it here, so I don't know.
What's that?
I don't know. I don't.
Yeah, right. It's not.
Okay.
Yeah. Yeah. The main thing I think here is the apical and the alars are
Gotcha.
definitely disrupted.
I misspoke.
and so you can see the impression there, 0 for 2. And so, yep. And so, plan for this patient. Luckily, orthopedics was involved and was going to take this patient for an occipital cervical fusion, occiput to C4 with iliac crest bone graft. The patient was placed in sandbags with tape over the head without, and I don't think there was a collar, but if there was one, they would have removed it and just did the sandbags. In addition to that, a large piece of paper was put over the bed that said, "Do not move this patient without us being there." So orthopedics had to be involved with any transport of the patient. And so,
Wow. So what was the head arrangement? Did you put him in a Mayfield?
I think it was in Mayfield.
Okay.
And then here's our post-operative CT scan.
What kind of a bone graft? Did you put soft bone graft in there? Or?
I think it was ground up. I don't think it was actually structural, like a
I see one
piece of
structural
tricortical.
graft. There's one structural graft in there. So how long since the injury, or how long did it take to do this patient's surgery?
Do you mean from the time of injury
From time
or
of
in
injury.
the operating room? From the time of injury, I would be guessing. I'm not 100% familiar, but I'm pretty sure that as soon as it was found, it was taken emergently to the OR.
So Andrew Dailey has joined us from Utah. Thanks for coming. Thanks for averting crises at home. So one of the most common problems we found at Harvard is that they distract. You've seen a couple of those. So what do you do? What are some tips and tricks?
Well, one thing is telling everybody that the you've got an AOD right off the bat, so alerting everybody so that they're not trying to pull on traction or anything like that. Put sandbags on either side of the head and then tape the head down like that. And the other thing you can do is if you think there's going to be a delay and they don't have a huge chest injury or a huge belly injury, you can even put them in a halo if you're worried that you're going to go. But that can be just as distracting as anything else. The thing I like to do is get them to the OR, like this gentleman said, as quickly as possible.
Yeah, luckily this patient didn't have like the need for an X-lap or something crazy like that, or a major internal bleed of some kind. So luckily he was stable enough to go to the OR pretty much immediately after diagnosis.
Why can I ask you a question?
Yeah, go ahead.
Was there a fracture of the C1 also? Why was not included in the fusion?
I think just it was not included just for rod contouring and avoid the extra surgical time in a critically ill patient. That's about the extent that I understand why most people, I think, skip C1 in their occiput instrumentation, but that could be up for debate.
Bijan, would you have included C1 with a
Absolutely,
segmental
yes.
screw?
Yes.
Biomechanics, or what's your reason?
Well, I think lateral mass of C1, if the arch of C1 is intact, is extremely powerful in maintaining good strength.
I have to ask the question because Rod and I have one disagreement in this world. Are you a C2 root sacrificer or preserver?
No, I've never sacrificed.
Yes. There's never a need to sacrifice a C2.
sacrificer amongst us.
Yeah.
I'm not going to give any.
Well, the
It was split where I was from in Akron. The newer surgeons
think-
would take it and the older guys did
I
not.
think two things are nightmare for me in this situation. One is bleeding, and one is the ganglion and C2 if it is sacrificed. I don't like it. I just simply don't like it.
So, Jens, I have a question.
Yeah, it's not.
Sorry, Andrew. Is there anybody in the room that would just do C1 to occiput? Because it's really the capsular ligament that's torn between the condyles and the lateral mass of C1. And if not, why not? And I have my own answer, but I'm just curious.
Yeah, the only problem with that, John, is that when you look at these, there's oftentimes a lot of ligamentous injury between the C1 and C2 lateral masses. And so you can see a high association. I mean, I don't see it, that many of them anymore. But I remember, when I was working with Jens, they all had C1-2 sort of ligamentous injuries.
I have
John,
the MRI
think-
up. Would anybody change their plan based on the edema of the soft tissue envelope between C1 and C2? Would that change your mind to go lower, or have like more screws below the occiput, like 6 above, 6 below, something like that? No.
No, I don't think so. I mean, to answer John's question, I wouldn't feel comfortable stopping at C1, mainly because the lever arm of the head is that's a big lever arm. It's not like you're dealing with a C2 fracture and you can just go one above, one below, but the head is so heavy that stopping below just at C1 I think that's asking for a lot of your C1 screws.
For me, the answer is right here. These are almost always C1, C2, and occiput C1 combination injuries. And occiput to C2 is a coordinated motion segment.
Can you show me the CT scan? I think C1, C2 on the left side is sick.
Yeah.
Yes.
Well, I would answer my own question by saying when I was a fellow at the Barrow, I had the opportunity to dissect a lot of cadavers for a study we were doing up at the cranial-cervical junction. The capsular ligament between C1 and C2 is actually like a bag. You can think of it as a bag. It really has no structure because it allows 45 degrees of motion in each direction, so 90 degrees total. So it really is loose to begin with. But what happens is, kind of as Wyatt was pointing out, the C2 vertebrae or body, I guess, is attached to the occiput by the apical and alar ligaments, which are disrupted in this case. So there's a certain degree of stability that comes from C2 to the occiput, I think, that we have to think about as well. And so that's why I personally wouldn't stop at C2. It's not so much about the lateral mass, it's more about the apical and alar ligaments.
Patient do.
Patient got a trach and a peg and a halo application. Here you can see their x-rays on post-op day 9. Trauma thought they had an abscess because of some fevers, so they made us take off the halo to get some more imaging, and obviously no abscess was found. On day 21, the patient finally awoke, and we have very good neuroexam. Here you can see their motor and sensory exam with some hyperreflexia. The right lower extremity was fixed anatomically here. Did have to be removed 7 months later for prominence of hardware, hinting at how well they did.
I was worried about that patella.
That's for all the orthopods in the group who were wondering how that did. So neurology was apparently consolidated for a cranial nerve 6 palsy from halo. That resolved spontaneously. The patient was discharged to rehab. At 6 weeks post-op, the patient was noted to be 5 out of 5 with sensation intact everywhere. Here's 12-week follow-up with persistent bone graft and, or 12 weeks, I'm sorry, and some evidence of maybe early fusion. Subjective bilateral shoulder weakness was at 18 weeks. An MRI was obtained by a PCP for some subjective numbness. Here we can see, so I had a question for maybe neurosurgeons who maybe seen this more than I have. Does the cord sometimes get adherent when you have like tectorial membrane disruption?
Probably the dura.
Or the dural
What do you think?
adhesions?
I mean, there's enough, I've seen a couple of these where there's enough of a velocity shear that they get, it's almost like an anterior cord herniation.
Yeah. Well, you know, I mean, it's like a cord injury anywhere. You can get tethering of the cord. And I mean, that's the problem. You know, you get subarachnoid hemorrhage and you get tethering of the cord. So, I mean, just like you can see it from a T5-6 injury, you can see it, I'm sure, up at the occiput C1.
And so the patient was eventually sent to a shoulder specialist who said that his shoulder, because his shoulder looked different than the left, and he felt weak with overhead motion. Here you can see the right trapezial atrophy. No impingement or shoulder pathology was found. And so an EMG nerve conduction study was performed, and the patient was found to have a cranial nerve 11 injury on the right side. And then the patient was lost to follow-up after that. However, he is working in a construction job, so doing very well other than those noted injuries. And here's a summary of the injury with his final follow-up at 1 year.
I was going to say trapezius wasting is cranial nerve 11, right? Deltoid wasting would be 5, but trapezius puts it up at the brainstem from the distraction injury at the cranial cervical dislocation. He's lucky that's all he had.
Yeah, hardly a third of our patients had cranial nerve injuries. So,
Bajan, I was going to ask you, I too would try and incorporate C1, but going to C2, first of all, I'll ask the speaker, if going to C2, how much range of motion in the cervical spine would you estimate that patient's going to lose by going occiput to C2?
I would estimate that they would lose about 50% of their flexion, 50% of rotation.
Yeah, I'd agree. So I was going to ask Bajan, if you incorporated C1, which I would try and do too, would you stop at C2 or would you go down to 4, 5?
Okay, so before saying that, I just wanted to see if you guys routinely perform CTA or not, because that screw bothers me without having a CTA.
A CTA was performed.
If the apex of the verts were okay.
Yeah, it was determined that there was safe corridor for bicortical screw purchase from these.
Number two, answering John, sometimes when we have a lot of difficulty convincing ourselves if there is a vertical distraction of C1, C2, we perform a stretch test. A stretch test is taking the patient to the CAT scan, either with one of our residents or myself. Probably Nathan knows about this. Use 15 to 20 pounds of traction, one CT before a stretch test, one CT after a stretch test, and definitely you would see the vertical distraction in that situation. Mm-hmm. Number three is that, John, if the C1 is not a Jefferson fracture, definitely I include the lateral mass of C1. And I think if the stretch test did not show that there was maximal 4 millimeter vertical disruption of C1, C2, I would not include C2. But if there is, which I'm very much suspicious on the left side, I would include C2. I would not include C3 and C4 because much of the ligaments over there are intact, and also you increase the lever arm of disruption of your occipital screws.
Great. So I had a question for you. How, and it's for all of our attendings here, how do we know that we have the correct angle? We've done the reduction, but how do we have the craniocervical angulation properly aligned? I see a lot of these being fixed into flexion. I see them being hyperextended.
Yeah. I mean, I don't look so much at the angles. What you have to do is, like, when you position the patient, you have to crawl under the table and make sure that the patient's head is in an appropriate position. Because, I mean, you can tuck somebody's chin back too far, put them in too much of a military chuck. They'll never swallow again if they wake up. And, you know, you can fixate them looking at the ceiling. You can fixate them looking at the floor. You have to look at it. And that's the only way you can do it. I mean, you know, you can, if you have a craniocervical anomaly and it's elective, you can have somebody get in the correct position preoperatively and then try to emulate that intraoperatively. The other thing is using an O-arm and trying to get, you know, the correct position from that. You know, after you position somebody, get the O-arm shots and actually, you know, then do your navigation and screws from there.
I mean, I know it's a pain, but you guys ended up putting this patient in a halo anyway. You could put him in a halo preoperatively and line him up exactly how you want him to, and then flip him over prone and have the bed attachment to the halo, and it's done before you even get into the OR.
Boom. All right. So,
I have to say, though, Jens, I agree with Andrew. In the operating room, once you're there, all I can imagine, and I've done, is lift the sheets and look at the head to the shoulders, and it's a gut feeling, right? I don't know if you or Rod have any other, or Bijan have any other suggestions, but it's just looking at the overall alignment.
I usually use the fluoro intraoperatively.
oh yeah. So patient did pretty well. Trapezius palsy, probably 1 in 3, and that's just the nature of the beast. Delay in diagnosis, but lucky outcome, no significant cord injury. The viscoelastic nature of the cord was strong enough to withstand the disruption of the tectorial membrane. Do you want to show us one more case and kind of try to do a little bit faster?
Yep.
Concentrate on.
So next one, 28-year-old male with back pain after an MVC, unrestrained backseat passenger without alcohol use, no significant past medical history. Here you can see our neurologic exam prior to any intervention. Here you can see deep tendon reflexes and rectal exam. So we can kind of go through, and I'll just skip through and give you some representative cuts. So here's what you can see. L1 burst fracture dislocation with sagittal split of L1 vertebral body with 100% lateral displacement and dislocation of the lumbar spine at L1. Here you can see the axial cut as well, how the surprisingly has been expanded
So
despite
Zach,
this severe injury.
I'm going to ask the AO question, dude. What is this in the AO world?
I'm unsure at this moment. Like,
A, B, or C?
oh, C.
Good. And that's all you need to know. There's no numbers anymore. Had to leave him to the trough. What about AO classification? Do you teach that at shock trauma?
The cervical spine, yes.
Yeah, we teach it as well. I mean, it just, you know, the type C. I mean, you know a type C when you see it.
Bingo. So this is, for once, an unequivocal thing. How much trauma workup does this patient need before the patient can go to the OR?
This was obtained during their kind of complete trauma workup, head CT, C-spine CT, chest, abdomen, pelvis with contrast. And at that point, there were no other supposed injuries. And so at that point, it was determined that he was okay to go.
Wait, so we get this straight. This guy just had back pain. That's it? Wow.
Oh, you have to understand, Ohio. Okay?
Not anywhere in Ohio, Akron, Ohio.
Akron, Ohio. Okay.
That's right.
Got it. How can this patient be neurologically semi-intact? Go back to the neuro exam for a second. Nathan, why can this patient be somewhat...
You can see it on, okay, yeah. I don't know if Jerry mentioned that, but you can see it right there. He actually he didn't destroy the canal. That translation, I don't know how the cord didn't end up translating there as well, but he expanded the canal there because of the fracture of the facet and the lamina at that same spot. So that's the only thing I can think of as to why, all the force translated laterally rather than, anterior posterior. So I suppose that the cord itself didn't take the brunt of the injury, just the vertebral bodies did.
How long ago was the fracture? Or was the accident?
Before arrival, you mean?
Yeah. Was it weeks?
Oh, no.
Acute.
This was presented this way immediately to the trauma bay. We got called.
So
Trauma can't miss this one, unfortunately. I mean, they can miss the OC injury, but it's pretty hard to miss where half the spine's sitting to the other side.
So the translation rotation is between L1 and L2, right?
This, I believe, was at
T12-1?
T12 L1. L1 is the bursted vertebral body at this level.
Yeah.
Yeah, 5, 4, 3, 2, 1, 12-1.
So
This is a conus,
That's
isn't it?
almost incredible.
Yeah.
So we'll continue here. The plan was to go to the OR for decompression and fusion immediately.
Andrew, how long do you have to wait at Salt Lake City to get the patient in the OR?
You can do it pretty quickly, actually.
If you're charmed, yes.
Occasionally.
And so here you can see lining up.
Are you going to get your MIS equipment ready?
No, this is an open procedure. This is an open procedure, and I, must admit that I use the O-arm a lot nowadays.
So 2 above, 2 below.
With a cross-link at the laminectomy levels. At this point, no anterior procedure was done. It was felt that an adequate decompression had been performed. This is somewhat of the CT that was demonstrated at the time. There was no formal at this level. I actually don't have that if that was available to prove that there was adequate anterior decompression. But we can kind of go down through these levels and maybe see what the cord looks like now. It's going pretty slow. Sorry about that. So left kind of expanded there.
No big laminectomy?
I thought there was. Let me see, right?
Okay.
Yeah, I think there was a laminectomy at that level done. And then, so this was his immediate.
So no formal post-op CT, although this patient technically had an incomplete cord injury?
I believe that is the case.
Yeah.
If that
That's
was performed.
That's one of my pet peeves.
Yeah.
I mean, for any complex spines, we like to get a post-op CT, not just an O-arm or 3D Zeme. And we should also get a formal CT and just...
So this patient did have retention and then persistent lower extremity numbness and tingling bilaterally. 1.25-year follow-up, his final visit, he's walking unassisted but does self-cath. And I believe he has a little bit of some hyperreflexia in the lower extremities. And then the left lower extremity does have some partial weakness in the dorsiflexors.
John, incomplete spinal cord injury, conus syndrome by all regards. What's the role of late decompression? Should he get investigated like CT myelogram, late MRI scan?
It's a good question. With a good CAT scan showing the fracture dislocation, I'm not sure MRI is warranted. And I think most of us would take this patient to the operating room within 24 hours.
Right. All right. A good case. Yev, do you want to go next? Sure.
And then, real quick question:
Yeah.
Does anybody use femoral traction if they're having a hard? If you just put them on the table, do they need that? You just pull on the legs. If it's completely translated, have you ever needed to do that?
Everyone's shaking
Wall fixation above, below, open reduction.
Okay.
Since I don't know how to do it, no, I can't use it.
Okay.
Good job, Jerry. Thank you. Yev Fravert from UCLA and UCLA Harbor.
All right. Let's see. Here's the first case we have picked out. So the patient in question is a 67-year-old male who presented after a mechanical fall with no loss of consciousness. The patient developed gradual onset of back pain kind of over the course of 3 to 4 hours after falling. He tried Tylenol, all of the standard over-the-counter things, and it didn't help. So he presented to the ED for further evaluation. He is a former smoker, but otherwise doesn't have any other major medical or surgical history. On exam, the patient has full strength, no sensory deficits, is barely ambulatory due to excruciating pain, and does have midline tenderness to palpation of the lower thoracic spine. This is his imaging, demonstrating that injury there between T11 and T12. Also notable is the extensive calcification and ossification of the spine, consistent with ankylosing spondylitis, possibly DISH. This is his MRI, demonstrating ligamentous injury to the ALL, no evidence of cord injury, hematoma, and no evidence of injury to adjacent segments. And then on the axial, there's no cord compression or any other pathology. So the options here. This is a fairly frequent situation. I saw it multiple times during training, and there are several ways to skin this cat. It's possible to treat this non-operatively in some cases. Possible to do this case MIS or potentially as an open fusion.
Go back to the MRI. So Wyatt, so you've seen these many times now also. First of all, the great thing is that our radiologists, I think, are getting better and better at identifying ankylosing disorders. I'm not sure whether that's just regional here, but they usually now call us finally. What are the boundaries of non-surgical care? This patient was neurologically intact, right?
Completely.
Can we go back to that MRI? Can we brace these patients? Can we just try to see whether we can get them up and get away with it?
Yeah, I think there is a role for bracing in these types of patients. When it's purely through disc space, or if it's purely through a healthy disc space, if you think about the two interfaces of the disco-ligamentous disruption through a disc, there's not much really there to heal. Whereas if it was purely through a very calcified disc space or through a vertebral body with ankylosing spondylitis, then you've got two bone interfaces coming together that can potentially heal with a brace. In this case, if you go back to the CAT scan, it looks a little bit like it's just right smack dab through the disc. I would be worried about this one, bracing this guy. My bias would be more toward a fusion, particularly if he was heavier.
Bijan, give this man a try. I actually literally have the same, Zach Tartarin joined us. I have the same case coming in transfer, right? Still coming in or arrived. Like neurologically intact. She actually walked from her injury from a car crash.
I probably should not say anything because my work is not thoracolumbar.
I know, but say something.
But I think, it's funny that I think this patient also has some evidence of possibly T1 injury, B1 injury, because the interspinous ligaments one level below and one level above. And above that is also, it seems to be disrupted.
That's I think that may just be the gantry. As far as I'm aware, there wasn't any significant injury below.
So pure hyperextension injury, so here B3.
B3.
Give it a try.
Boy, I don't know.
Save me from having to operate tomorrow.
The thing with non-operative treatment, though, Jens, is it's a lot of work to go ahead and follow these patients very closely. This is somebody you're going to want to get upright x-rays on immediately. You're going to want to get upright x-rays on in a couple of days. This is not somebody who can come back to see, your PA in 6 weeks. This is somebody you have to follow very, very closely, I think, if you're going to treat it non-operatively.
What would the ideal brace be?
That's a great question, because they would be better in a little bit more flexion as opposed to a hyperextension Jewett type of brace. So, I think a custom TLSO.
Yeah, and remember too that bone posteriorly in Enk's spondy, that is brittle, not strong bone. So you can't really rely on that to hold up that anterior column like so. John vehemently disagrees. I know he does.
Surgery, AO, always operate?
No, I think my Canadian heritage is coming in. I'd probably give a trial of a brace. If this is going to fail catastrophically, we don't want to see it fail in translation. But it really has only failed in extension, and the posterior elements look intact. So I think there's a good likelihood this should hold up to a brace.
So my patient from earlier today, who's I've still not laid eyes on, apparently walked from the car crash home and then had herself transferred in, but she's still walking apparently, and she's big. Operate? Okay. All right. What'd you do?
Yeah. So, given that the PLL was intact and the injuries seemed to be limited to the ALL and the kind of the anterior portion of the disc, we initially tried to brace the patient with a TLSO that was fairly well fitted, but the patient couldn't weight bear. The pain was just too severe. So percutaneous fusion was offered. It was a navigated T9 to L2 fusion. It went uneventfully. The patient was discharged on post-op day 4. With the recommendation to wear the TLSO when weight bearing, and he's doing well. I think at this point, approximately 3 weeks post-op. This is his final imaging. Conveniently the patient's spine was very very straight, so we didn't even really have to contour the rods because they slipped right in.
What table did you do this on?
This was we discussed potentially using a Wilson frame, just to facilitate a little bit of flexion. If I recall correctly, we did it on a standard Jackson with just a little bit of extra padding to facilitate the flexion, just to make the O-arm easier to fit.
That X-ray, that graphic looks like the X-rays you just showed on your title slide. Go back one slide. No, go forward. Never mind.
Oh, sorry.
That actually looks like. That graphic looks like your X-rays.
Yeah.
Never mind.
Straight.
Very lame.
All right. Second case, 57-year-old female with an extensive smoking history, had COPD for many years with a recent transition to oxygen dependence. 1 month prior to presentation, was diagnosed with right upper lobe adenocarcinoma. Her pain, and I'm sorry, I didn't include this here. The other symptom that was almost incidentally discovered was several months of this kind of mild to moderate progressive neck pain, which was mostly well controlled with routine analgesia, but in the last week or so prior to presentation was becoming difficult for the patient to tolerate. She presented to the ED for increasing shortness of breath. Her physical exam was mostly unremarkable. She was full strength, no sensory deficits, although her lower extremity did exhibit some brisk reflexes. She did have mild neck pain with range of motion. This is her imaging for the main presenting complaint, which is a shortness of breath. She had that fairly large right-sided pleural effusion that was associated with her newly diagnosed tumor. But the ED decided to work things up a little bit further, given her neck pain complaints, and this is what they were able to discover. It's fairly clear. What the issue here is.
Dr. Arabi, so this patient, on further digging, at age 16, had a severe car crash, had a bad femur fracture that was treated in traction with like 6 months of bed rest, or 4 months bed rest, 6 months of a cast, but she was at bed rest basically for half a year. She does not remember any of the injuries, but what do you think is going on there?
Well, I think.
Can you toggle to the CT scan?
I do have a CT, but it's post-op. For some reason, the OneDrive deleted my CT slide.
I think immediately what the patient needs is to have some kind of traction to see if he can reduce it or not. Was it done or it was not done?
My fault.
Was not. Okay. So if we do not have traction, I would use the traction to see if it is going to reduce or not. If it is reduces, then I would go posteriorly. If it does not reduce, I would go and do a resection of the odontoidectomy. Yes.
Jens, is there a congenital anomaly here too? Was there an assimilated C1 as in association?
This is an old, neglected type 2 odontoid fracture, basically just healed in a severe malunion/nonion. The upper tip, the CT would show it in continuity, so that's why I was asking to toggle to the CT. So sadly, that's not there. But this is not a congenital dysplasia. There's no oncologic problem here. This is a old malunited odontoid fracture with posterior subluxation and listhesis of C1. All right, so now we have a new tumor disease. Should we operate or not? John, what do you think? Or should we do Canadian healthcare, or should we kind of use the window? They want to start with chemotherapy in about 2 to 3 weeks. That's no joke, because the Christmas holidays can't be violated. So they want to start oncologic care. You have a little bit of a window of several weeks. Do you want to fix this, or do you want to wait?
Oh my God, yes, please fix this.
Fix this?
Yes.
What's your suggestion?
In my mind, this has to be a transoral.
Transoral.
Yeah.
So she'll get radiated there.
I can't help that.
She's almost intact. She has mild hyperreflexia.
It's not going to be that way for long.
I know you have limited images, Dr. Rabi. Is this myelomalacia? Is this a cord edema?
Well, there's no question there's signal change in the cord, yes, myelomalacia. But I think really, I would like to have a traction overnight. If this patient reduces, I would go posterior. If patient does not reduce, I would go anterior.
Andrew? Bijan, traction?
Yeah, I like the traction. I mean, there's no harm in trying traction, that's for sure.
All right, tell us, interest of time, what we did.
Yeah, so
line me up for a target practice.
Yeah, after pretty extensive risk-benefit deliberation with the patient, we offered occipitocervical fusion from O to C5, as well as an L1 laminectomy.
C1 laminectomy.
I'm sorry, C1 laminectomy, correct. The intervention was uneventful. This is a case we actually did just a day ago. The patient is doing very well, surprisingly minimal pain. With an intact neuroexam, absolutely no changes to her strength or sensation.
You had a post-op CT?
Yes. So this is the post-operative scan. You can appreciate, again, the gantry is a little bit off, but you can appreciate that malunion that you were talking about of the dens.
So odontoidectomy, John, this is an invasive procedure. I used to do a couple of those at UW. I almost don't have to do them anymore.
I know, it's rare.
Any thoughts? Am I doomed? Have I burned any bridges by doing this? This is too invasive. What are your thoughts?
By doing it posterior, you mean?
Yeah, just doing posterior decompression.
Well, I don't think, to be honest, I don't think you have a proper decompression. You can still see that C2 fracture is angled into the spinal cord, so it's decompressed at the back, but that's an indirect decompression, right? I think if you'd come in anteriorly and taken off the ring of C1, as well as the upper 2/3 of C2, then that cord would be in a better position. But I can't argue with the outcome. The outcome's good.
So far.
Yeah.
John, are you doing your transorals open now, or are you doing endoscopic?
So to be honest, Andrew, it's been about 5 years, and I would like to do one endoscopically, but I haven't had the opportunity.
How does that work?
Game changer. We have somebody who's trained endoscopic now, skull-based surgeon endoscopically. Yeah. It really makes it a much less morbid procedure. I'm shocked. I think there may be a bit of a renaissance.
I've done it endoscopically on a cadaver, and it's a sweet operation. Yeah.
Bijan, would we approach this phonodontodectomy submandibularly or a transoral? How would you do this?
I'll go transoral and split the soft palate, and it's very easy. The main thing is that this patient is a cancer patient. We may have difficulty with healing of the transoral approach, but still, I think the preferred choice for the first approach is traction.
Okay. All right. So far, so good. Yeah. We actually have a logistics problem, Rod. We don't have traction anymore here. We have these incredibly expensive striker beds, and they don't have these hill ROMs. They don't have traction anymore.
Yeah, I mean,
I like to use a Jackson with Gardner Wells tongs for traction on this case. Yeah, I mean, I don't even use a Mayfield anymore for doing posterior cervical spine cases. So.
All right, so far so good. Do you have a third case?
Yes. So third case. 65-year-old male, pretty extensive medical history, dementia, alcoholic liver cirrhosis, hepatic encephalopathy, type 2 diabetes, pretty much everything. Patient was found down in his yard, presented to the ED complaining of significant refractory back pain, was also noted to be fairly confused, and had no other focal symptoms. On physical examination, the patient was partially oriented, name and location, didn't know the year. Was neuro intact with maybe a little bit of lower extremity hyperreflexia, and had no sensory deficit. Because of the back pain, a CT scan was obtained demonstrating this lesion right here. An MRI was subsequently also obtained of the T-spine, demonstrating no cord compression and primarily bony injury of T9.
So in the interest of time, can we agree this is a B3 injury, John?
I have no idea what that means, but sure. Okay.
So our classification system, AO, doesn't matter. Okay. All right. Well, do we have a fellowship spot next to your Rod? No. So hyperextension injury and an ankylosing spine in a pretty morbid patient. So he showed a successful case with a percutaneous rod before. Same discussion again. Try him non-surgical. He's pretty sick. Alcoholic liver cirrhosis. I don't know what his status is, but he's not well. Percutaneous rods or open fusion.
You're looking at me, so I'll jump in. But I just want to have a real close look at the posterior elements, the facets and the interspinous spaces, and make sure there's nothing, the fracture extending through them. If it is, then I'd instrument. If the posterior elements are intact, I'd probably just leave him in bed and then reevaluate him week to week. He's not going anywhere quick.
So he was pretty sick. He had a large abdomen from his liver disease and ascites. So the decision was made to...
So initially the patient was very decompensated and couldn't tolerate surgery, needed a couple days of optimization, apparently had been down in his yard for multiple days, so they needed to treat his rhabdomyolysis. He was eventually taken for percutaneous fusion with a mini open debridement at the fracture level with some facet decortication. Unfortunately, the bone quality was reported to be poor, so several levels couldn't tolerate screws, as I've demonstrated on the scan to the right there. The patient did well initially, was discharged with good pain control a few days after surgery, but proved to be pretty unreliable and was lost to home health follow-up just a couple weeks after discharge. He represented post-op day 19, found down in an empty house with no furniture, positive for amphetamines, septic with a fever to 103. He was grossly infected. There was fluid leaking from his incision. So he had to undergo revision, was taken for open revision from T6 to L2 with plastic surgery assisting with the closure. Was subsequently discharged 1 month later due to a pretty rocky hospital stay with multiple episodes of sepsis and decompensation. That wasn't the end of the story for him. He presented 2 months later with a delayed wound breakdown, which was found to be mostly uninfected. It was repaired again with plastic surgery, and he was discharged a few days later. He seems to have a declining outpatient course and is currently lost to follow-up.
So this is an MIS case, Andrew, of a pretty depleted hyperextension fracture patient. You see the downsides. This is, I think, superficial, right? This is not.
Yeah, this did not.
So he abraded his skin there. But are you damned if you do, damned if you don't? Should we just not treat these hyperextension injuries in a depleted patient? Can you show the MIS surgery that had pulled out?
No, I mean, I think you have to give it a shot. The question is, the only problem with MIS is sometimes, getting bone graft in there is what worries me. And I understand, with just a hyperextension injury, you're just trying to ankylose that one disc. But sometimes if you pack a bunch of bone in there, I think maybe they might heal a little bit better. And that's my only problem with MIS sort of interventions, is where are you getting the fusion, really?
Jens, I thought MIS wasn't supposed to get infected.
I did the second surgery. I didn't do the first surgery. I did the open part, and it promptly dehisced the wound. So this is like what they say. But again, he actually got infected the first time already, and he had gram negatives. But I sent a video to Yev, but he couldn't download it.
Yeah.
The first time, you could literally pull the rods out. They were just completely loose in there. So we did in our surgery, then in our second surgery, if you go to the next one there, we did bicortical screws, very large caliber ones. And
Did you pack a bunch of bone?
yeah.
You fused.
Yeah, we did a proper fusion, yeah. And we did a decompression also.
In residency, we actually had a car accident patient, very young guy, I think in his early 20s, with a simple fracture that we perfused. It ended up getting infected just a few days later. We put him on PO antibiotics, and then he went to prison, returned a few months later with a completely healed incision. So maybe sometimes MIS takes care of itself.
Right.
All right.
Did you put carbon fiber rods in there?
No, that's an intraoperative shot. We did standard rods. All right. Zach has a quick case just pertinent to this one. Thank you, Yev. Great job. Which case do you have, Jared? Okay.
The lady from Mexico. And then
Oh, yeah.
you did this. Yeah.
So Zach Tartarin has 2 cases, I think, right?
Well, no, I just have one, but
Just one.
I'll show yours that's incoming. And see what people, oh, sorry, that's my dial. Oh, thanks. So I'm Zach, neurosurgery, spine fellow, McMaster in Canada. This is a case that's coming in, I got called about this morning. I'm on call with Dr. Chapman.
I want everybody to vote. Who is for surgery? Everybody votes. Who is for non-operative? Annika, why would you raise your hands? Who is for non-surgical care? This is coming in, neurologically intact. She walked from her car crash to her home. I've not examined her yet.
And then she drove to the ED.
And then she drove to the ED. She's pretty big from what we see on the CT scan.
Is that a fracture through the facet?
Yeah.
Yeah, it looks like it. Fix? Wyatt? Non-operative? Annika? Cliff? Don't fix? Which case do you have, Cliff? You have a case, okay. All right. What are we going to do? It's you and me.
2 up, 2 down.
2 up, 2 down. Tomorrow afternoon. Okay.
You want to do tomorrow?
Tomorrow afternoon. Let's examine her.
Oh, after the course.
After the course.
Yeah.
Sunday,
After the course.
Sunday.
No, let's do it tomorrow. Let's do it tomorrow.
Okay. All right. Show your case. This is a rod.
This is just a quick case we did last week. This is a 60-year-old lady with back pain, occasionally bilateral leg pain for a month following a motor vehicle accident early November. She was full strength on exam. She was initially placed in a TLSO brace for this. So AO, A2, split fracture. Her back pain persisted, was getting worse. The TLSO wasn't working as well as it had been, and it looked like it wasn't fusing. So, what to do?
And it was a high velocity. The person actually died in the other car. So, and she's like a month out. These are difficult cases, where they come in and you see a scan like that, and her pain was getting worse, but neurologically she was intact. What do you think, Andrew?
I was going to ask you, because we've played around with this a little bit, just like perking him L3 to L5 and then trying to do like an MIS corpectomy. And, like kind of listening to you over the years, you kind of like try, kind of influenced folks to try to do this. And we've played around with it. I mean, it's like, for us, it takes a long time to do it. But would you do this, would you do it that way?
So my difficulty in her was that, she was a month out. But if you look at her scans from when she first had the injury, it's like it's falling apart. And it's getting more and more. And she's got, it's almost like a wedge kind of fracture. And so what I've done now, like if it was more of an acute fracture, I think I probably would do what you said. I think for her, we talked about, different options, and we did it open. And I don't know, John, what your thoughts are, or Wyatt, or Bijan, but, because she kind of failed, it's a month out and the thing's falling apart, I kind of was more, and again, I think if it was fresh, I think you could get away with a perc maybe, and then maybe doing a lateral anterior corpectomy. But I just didn't think this was going to heal. And she's fairly young and just the mechanism injury. So I did it posterior, and then we talked about, I told her, I said, look, we can always come back and do anterior corpectomy. But I don't know what you think, Bijan or John.
I pass.
What's that?
I pass because I don't have much experience.
Oh.
Yeah. What do you think, John?
Well, because she's a month out, I agree with you. I think now's the time to be a little more aggressive than at the onset. So in my hands, I would do bilateral pedicle resections of L4 and do a partial corpectomy bilaterally and put bone graft in. You can't get a cage in posteriorly easily because you're going to have to sacrifice a root, and that's not an option here. So, but I would be aggressive taking out the discs above and below, as much bone as I could, putting new bone in, and then I think if she's got strong bone, I might just go one above and one below.
I wouldn't do that. Sorry, John. I personally, she is 1 month out, and like you said, Rod, you've always got room to go bigger if you need to later, particularly if she fails and she doesn't fuse with just a posterior operation. So for me, I think I would do L3 to L5. I would put in bicortical screws. And really, and you really don't even need to decompress anything posteriorly, so you can really just decorticate the hell out of all the bone back there, lay down bone graft, and probably get away with just that.
So you're not going to do anything anterior?
No.
Huh.
It's an AOA4. I mean, I have changed under Rod's experience.
Is it A2?
This is upper and lower vertebral body is impacted and blown. This is also a pincer, a horizontal coronal plane pincer fracture.
It's so great to hear you guys argue over that AO classification.
This is what we used to do in Davos, right, John, year after year. So I think for her, the lesser problem would be a one above, one below, a posterior decompression, ventral disimpaction, then you do an XLIF. What did you do? Short screw. Oh.
Wow. Vertebroplasty, screws at every level.
And post up. Wow. And just leave it like that?
There's rods too on either side.
I know.
Yep.
So no anterior column support.
I talked to her, and I think, Wyatt kind of has done a couple of these with me, and I just put short screws in at L4, and so I could still go and do a corpectomy and sneak it in. And she just, I just didn't think she was going to heal. And so we'll probably end up doing a lateral corpectomy, but I wanted to kind of, she was still pretty beat up about, the whole accident and everything. But I like these fenestrated screws, because her bone quality wasn't great, and they kind of provide immediate,
Did you make that decision before?
Yeah. No, before, because we did the Hounsfield units, and she's got a little bit of osteopenia, so we'll see.
Jared has, I think, a follow-up case. You're showing the one that you showed in Las Vegas last week? Yeah, good. Jared Cook, one of the other fellows.
SSF swag on.
Thank you, Zach. Good job.
Oh, but now we're logged out.
Uh-oh. Ben to the rescue. So again, short segment fixation with cemented screws, that's a new variable because, again, historically they would fail without an anterior column support.
Thanks.
Both end plates are depressed, so A4, comminuted body. The body is gone.
We're working, we're up. All right. So again, I'm Jared Cook, and so here's our case. So we had a patient, 40-year-old male with Down syndrome, mostly nonverbal, just kind of communicates by smiling and nodding, and presents with low back pain for 9 months after falling from a 6-foot-high structure like a retaining wall, and it's become progressively less functional. Mother, as a good historian, reports that he's been kind of pitching forward with his posture and has become non-functional, has to ambulate in a wheelchair at this point, whereas he was previously independently ambulatory, but he doesn't have any neurologic deficits that that we can tell, that his mother can tell. He had X-rays at an outside facility and was diagnosed with a quote possible pathologic fracture of L4. It was biopsied, no neoplasm or infection. The exam. He moves everything to gravity, moves everything spontaneously, can't really give a reliable exam, so, but he's moving everything intact enough. And so here's what we see. I'm wondering how this is showing up here, but if you can see L4, it's totally wedged. You have a kyphotic deformity there, as well as coronal plane deformity and new bone formation. Happening at that L4-5 level on the CT. You can see that a lot better, as well as some AVN. And then on the MRI, so there's no neural element compression. And so with that.
All right. So John, he received Canadian treatment.
I feel like you're trying to trick me.
There's no trick in there. There's no tumor. There's no infection in there.
Back up to the physical exam. All right, tell me how you get grade 3 strength in elbow flexors and extensors from an L4 problem.
There's no craniocervical junction thing, but that was imaged.
Really?
The patient is a trisomy 21 patient, so you're very insightful. But basically, this denotes anti-gravity strength, but you can't go beyond anti-gravity strength.
I'd be really worried about something at the craniocervical junction.
We actually imaged it. You'd be proud of us.
Jared, what would you be worried about in a Down syndrome patient at the craniocervical junction?
The C1, C2 instability would be the main thing.
ADI?
Yes.
Yeah.
Or basivertebral invagination. Have you seen those, Bijan, in trisomy 21?
I have not.
Okay.
All right, so we're going to focus on L4.
L4 is the on it. There's no trickery in the craniocervical junction. This is an L4 lesion only, and it was biopsied negative because the outside surgeons thought this was an oncologic problem.
Yeah.
He probably, in retrospect, had a neglected fracture. He couldn't verbalize it. He is one of those moms who's amazing. She knows every single beat of his eyelash and what it means. And for us, he
honestly,
grunts.
what I would do, I would probably ask Wyatt to tell me what to do on this case.
So yeah, this case is a little bit different than the last one just because there's so much bony destruction there. So while last case I felt pretty strongly we could get away with just doing posterior instrumentation and fusion, and since there was no neurologic deficit in that one also, this one with so much destruction there, and even that lateral bony formation off to the left is kind of incompletely formed. I think this one is a good one for lateral corpectomy and cage insertion.
Would you do that first?
Probably, yeah.
Okay. So, Andrew, any thoughts?
I'd go pretty big. I'd go L2 to the ilium posteriorly, try to reduce them, and then put a corpectomy cage in front, hopefully from a relatively less invasive approach.
All right. Show us what we did.
Well, So a two-stage procedure. Started off posteriorly L2 to pelvis with a quad rod construct and decompression, and then 7 days later, L4 corpectomy done laterally. So here is from stage 1, restoring that lordosis, which was quite difficult, and then after stage 2, just kind of had to use the CT Scout to show you this. Now let's hope that we can get this guy to play.
So this posterior reduction was actually really hard. I do a lot of kypher reductions, and I pride myself on being pretty aggressive with that, and that was hard work. His bone was actually pretty good, and there'll be a sequitur in a second.
So.
Can't play it? Can't play your video?
Can't, but we have, I can show you the kind of final x-rays at this point. So clinically he's doing well, sitting without much pain, like.
Can you go back just so Dr. Oskuian sees it? Rod did a beautiful XLIF here. So this is how I've changed my burst fracture treatment. I do a post-instrumentation, do a quad rod construct, again, a very aggressive release, and then he did a, can you go to the sagittal, please, Jared? He did an XLIF. And really, the question was, could you jack out this from the front as much, or does the posterior surgery help you?
The posterior surgery really helps. What's amazing, actually, I remember this case vividly, is the plexus is right there. So what I do, I can't remember who did the case with me, but I just found the plexus, and I just put my retractor right in front of it. And then I usually, once you find the plexus, then, we actually got, I don't know if you can measure it, but you can distract it open even with the posterior instrumentation. And I don't know how that's possible. I think it's because multi-axial screws, but you can literally jack this up. The only limiting factor is obviously you don't want to piston through the end plates. But it's pretty powerful.
But so yeah. Rod, you jacked that up with the posterior instrumentation locked already?
Yeah, and I can't explain it. The only thing I can think of, John, is it must be because the screws are multi-axial.
Wow.
Because they're not, right? I mean, they're fixed to the rod.
This is a quad rod construct.
And it's a quad rod construct, but I don't know if you saw I think, at least intraoperatively, you can just sit there and keep dialing, and the bone's going to eventually give. It'll fracture, so it's kind of you don't want to go too crazy because it will just piston right through it. But it's incredible how much, you can really get a pretty significant amount of, correction. Obviously, there's biomechanical restrictions in terms of, but, I think it's yeah.
So he's doing well clinically, but he's starting to pitch forward again. The CT looks great, but on the X-ray.
So now what should I do? Should I intervene soon or late?
It's so interesting. I think the cage collapsed a little bit, didn't it? Jens is going to not be. He's going to have to go in and extend it up to T4. Don't you think did the cage collapse a little bit?
Yeah, it looks like it kind of flexed in its expansion a little bit.
Medtronic.
This guy is counting on it. He was up walking day 1.
Was he?
Yeah, so.
He's pretty fierce. What are you going to do?
IDO.
Oh my God.
Should I stop at T9?
No, I think you got to go to T4. Do we have Scully X-rays? Look at that curvature.
Yeah.
He's really.
I just feel good that Andrew said the same thing that I ended up doing. I was very pleased.
What's his bone density? I mean, it doesn't look very good.
It's fine. He has obviously a genetic collagen problem. Nathan, do you want to go last? And then, Perry has one more case also, and then we'll finish. Thank you, Jared.
Did I hear you say T4?
Andrew said T4.
Why not
so I'll do what
T10?
Andrew says.
Why not T10? I didn't see how high it went, but
So far we went to L2, but I don't want this to happen again. He walks forward pitched.
Oh.
So we straighten him out.
His sagittal malalignment's probably 15 centimeters at least.
Yeah. I'm tempted to want to go high on him now.
Makes sense.
All right, so I have a couple of quick cases that are a little different from what we've seen so far. First one is a 73-year-old female who presented initially to an outside hospital about a week before she saw us with several months of worsening gait dysfunction that had been managed kind of conservatively by her family physician without any workup. She'd been undergoing some physical therapy. About a week before, she showed up to the outside hospital having some subacute worsening, decreased sensation in the saddle region. She got an MRI and was discharged home. Just an MRI of the lumbar spine, was discharged home, and then came back to see us. She denied any recent trauma or falls at the time of the initial assessment. Past medical history is significant for, and I'll show you the MRI they got at the other hospital in just one sec. Past medical history was significant for a kidney transplant, on immune suppression. Surgically, she'd never had any prior spine surgery. She did have a recent obliteration of an AV fistula she'd had in her right upper extremity. She's a retired orthopedic nurse. Otherwise, not very exciting past medical stuff there. This was the only image that was obtained at the outside hospital before they sent her home on a Medrol dose pack. You can see a grade 1 spondy at L4-5, but not a lot of significant central canal stenosis. And the patient's been having gait dysfunction. Interesting management there. When she arrived here, physical examination first, she had some early signs of spasticity and contraction in both hands, some decreased sensation in the saddle region, but was still able to feel. She actually had a PVR at the outside facility that was normal, was 0. Even though she'd been reporting she had difficulty sensing the need to void and felt like she was retaining. You can see she had upper greater than lower extremity dysfunction on her physical examination, brisk reflexes throughout, clonus in both legs and Hoffman's in both uppers. This was the MRI obtained when she finally reached us. You can see significant stenosis both anteriorly and posterior at C4-5. On the T1 post-GAD, this was read as a infection. This was read as possible or probable abscess by the radiologist. Even though the patient exhibited no signs or symptoms of infection, otherwise all of her lab values were totally normal. She had no fevers. She had no overall malaise. Overall, the CT was then performed negative for any acute fracture. On the CT was the read, and there was nothing obvious on it that we reviewed. The treatment strategy at that point, the presumption was that the patient had either an infection or just chronic myelopathy that had been worsening over time. What we did not know was that the patient had actually had a fall and had not reported that to us. Despite being asked directly, have you had falls? She then said, oh, I actually have. So the plan was to move forward with an anterior cervical discectomy and fusion. She needed decompression stabilization at that level with poor bone quality due to her kidney transplant and the need for additional fixation if she was going to go posteriorly. The plan was to try an anterior approach first. Intraoperatively, talking with Dr. Squillian, there was evidence of ligamentous disruption as well as a hypermobility at that level, indicating that she'd had a hyperextension injury. So that was the rationale for our surgery. She had improved strength, discharged home on day 2. I think that it's an occult central cord injury that looked like just chronic myelopathy with a possible subacute worsening due to some sort of an infection, but that was clearly not infection, at least based on what we saw intraoperatively and what all the labs told us.
Can you go back to the MRI?
Yeah.
So Bijan, what MRIs should we nowadays get? So in this case, that emergency room got
the 4-5,
contrast.
First of all, we get a T2 weighted image.
Yeah, they don't. They only had this medic, this T2 medic. This is like a recon. I think that she was moving too much to get a real T2 image. It is a T2, but they don't have like a normal FSE T2. Sorry.
But there is no question at 4-5 there is anterior compression as it was correctly. But I think still has got some stenosis from C3 to C5, whether that needs to be managed or not, based, I suppose, that MRI on the right-hand side is still pre-op, right?
Yeah, all that's pre-op. The one on the right, so just assume that the pre-GAD, there was no hyperintensity on the pre-GAD MRI. So all that is lighting up with gadolinium. Yeah,
So for a mild degenerative cervical myelopathy, or I'm not sure if this patient had a fall or something that could classify this as a central cord syndrome. I think the compression has been pretty successful from what I see. So I think unless it is terribly needed, I would suffice the present approach.
Yeah. Yeah, if she did have a fall, it was occult because she didn't tell us about it. And so the presumption going into the operation is maybe she has osteomyelitis or some sort of an epidural abscess, but nothing clinically suggested that other than a read from radiology. And clearly what we actually saw.
You had said that was epidural abscess.
They did.
Potentially septic arthritis.
Yes.
Well, I don't know.
Nothing else suggested that, though. No.
It's kind of one of those, where they kind of, everyone went down one lane, infection. And then we kind of talked to her for a while. She's actually an old orthopedic.
Yeah.
And we talked to her, and I said, look, she's like, yeah, I've been more clumsy, and ever since I fell, I've gotten worse, and so.
So Bijan, in an incomplete cord, assuming this is central cord, should we get a postoperative MRI scan, and if so, when?
Immediately.
Right away.
But tomorrow I'll talk about this, but it depends on what is your degree of deficit. I couldn't see any signal change in this cord.
No.
So if there is no signal change,
very minimal, right at that level.
Even if there is a minimal signal change in the cord, it's not going to go crazy and expand. So it's going to stay the same. So the question is that whether, if that calcification of the ligament of flavum, which is at C3-4, whether that is, or it's at C4-5. Can you show us this CT again?
Oh, sorry. Yeah, this one.
See,
you can see calcification.
Post.
Post-op, right there, sorry.
See, there's between 4 and 5 that the ligament of flavum is calcified. So whether that's going to play a role or not, I don't know. You have a good post-op MRI?
No, we don't have an MRI. I mean, I know that's what we would have done.
So with no post-op MRI, I cannot say anything.
Yes.
So you're going to post-op MRIs?
This is me. I always do. I'm so insecure.
If they have cord signal change or just have one?
Well, this patient, by default, has spinal stenosis, and by default has signal change. You said mild signal change at 4-5. So he has degenerative cervical myelopathy or post-acute traumatic central cord syndrome. How you manage this for a AISD, which is this patient, I don't think there is any need for posterior decompression because that signal change is not going to change for a long time.
Good. What are you going to do now? You going to do posterior or repeat MRI?
I mean, it wasn't whether we're going to, I think the question is, do you go from back, do you go from front?
That was before the surgery. Yeah, what are we going to do?
I do the front also.
But we kind of move front.
All right, what else do you have? Otherwise, I'm going to show
the last case is this 46-year-old female who is now 4 weeks status post an urgent T2 to 6 posterior thoracic fusion for an unstable fracture after it's an AO4 at T4. We'll see that in just a second. Unfortunately, I don't have their preoperative imaging. They didn't send this with her. Sustained after a fall from an 8-foot wall. Patient was vacationing in Mexico, out for a night socially, and fell from this wall. She arrived in clinic after returning home in a TLSO brace. She denied any focal weakness, no ambulatory difficulty, no incontinence. had some mild back pain, but said this has been improving significantly. No significant important past medical history. Was a former smoker. Her physical examination is essentially normal. She's no abnormal reflexes, and she's full strength throughout. She has a surgical incision that's well healed, just minimal tenderness, but no signs of any sort of an infection or anything like that. And she's walking around the clinic with her TLSO brace without any difficulty. I'll skip over that and just show you what the actual imaging looks
So
like.
this is treated in Cabo, in Mexico. This is a citizen. She has a very successful business. She's single, nice looking, nicely taken care of. And she had a near catastrophic injury. There's no history of any cord injury whatsoever. And our colleagues in Mexico put these screws into her. And remarkably, they gave her a English language list, which basically pointed out every single mispositioned screw, in all honesty. I thought the transparency of this was pretty dramatic. She has pretty small pedicles when you look at that also.
Yeah.
So the burst fracture is unreduced. There's been a laminectomy done, a small little pseudo-laminectomy. And again, literally at every level, there is a problem with some of the screws. She's hanging on 2.5 or 2 screws on one side and 2 screws on the other side. But she has no pain. She has no pus. She has mild hyperreflexia. She walks and balances pretty well. So let's start with Wyatt and John. So this is a patient who ends up in your clinic. I actually would like to have your opinion about this because she's under active care by me right now. I'm not going to tell you what we did, but she basically is neurologically normal and has some pretty crappy hardware, but it's somehow holding up.
Yeah, I looked at John right before you started talking, Jens, and I said, that screw's bad, but it's probably not hurting the cord.
Yeah.
Without any, I forget, I don't know which level that was, but without any radiculopathy, or with T2, without any T2 radiculopathy, or without any upper motor neuron symptoms, I probably wouldn't.
None. And I probably wouldn't. Very carefully.
I would leave it alone.
Yeah.
Alignment is good. No myelopathy. John, leave it.
Yeah, follow her. Leave it.
Bijan, I know you want to deflect.
No opinion.
No help. I need some help. Should I revise this or not?
Leave it alone, man.
I showed it to Rod.
In this case, I think you're doing the right thing. I would leave it alone. Yeah.
That's what we had. Yeah. We went through this. I actually followed her weekly, and I think she's 2 months out now so far, and she's holding up. So we're now going into 2-week intervals.
So will you take it out once she
That's a great question. That's asked as a question back because her Mexican surgeons told us she should have the hardware out. Now, they did a pretty big laminectomy there. I'm inclined to not take it out. Or if I took it out, I would want to do a bridging rod construct or something like that. I'd wait. What I actually told her is we'll wait for 3 months. We'll get a repeat CT, see if bone starts consolidating. Reasonable? Okay. So far, so good, right?
Yeah, this
that's a nice
most recent one is actually from I think this week or last week on the right there. So
she's very compliant with the brace wear. She has her Gucci shoes every single time. Last but not least, we're going to the bottom of the spinal column, the sacrum. Perry Godolph is from Germany. He's a research fellow here. He's done some very cool projects. He has the first experimental model of I think I can divulge that, of a 3D reconstruction of a lumbar plexus based on MRI images only. Bijan, you'd be so proud of him. He's using MRI images to recreate soft tissue structures.
You can just briefly show a picture if you want to.
Yeah, sure.
Exactly.
You have to have an NDA from everybody. So the cool thing was that he can show where the lumbar plexus is relative to the psoas musculature in great detail and map and plan out where possible, Rod's idea, where possible, cages can go safely.
Can you do this with every MRI? I mean, like if, your MRI versus my MRI?
I wish, not yet.
There's a little tech trick with it, but yeah. But I think the MRI signal detection and discernment technology is rapidly advancing. All right. 1.5T. All right.
So great. I
Very
have
good,
a
Elias.
really short case and something else than the other things that we have seen so far. It's about the elderly. So we have this 50-year-old female, a little too heavy for her height, and she is well known in our hospital. So Dr. Chapman treated her already because of a metastatic breast cancer disease with corpectomies in 2015. And some other things, as you can see here. Of course, she has all the comorbidities that we would expect from such a patient with this BMI. Then she came back to the hospital basically because of an urosepsis, and there she noticed that she had some pain. So we did some examinations and did some CT scan, and what we saw were these CTs. So we had a CT already in 2015 and the years after, where we saw lytic changes in the ileum and in the lateral mass of the sacrum. But back then they were still intact, and now she came back with an insufficiency fracture or fragility fracture of the lateral sacrum ala. So as you can see, the fracture here, it's a fracture which, from my point of view, includes the articulate process of the sacrum, and then it goes basically in, I would say, then is zone 2, and then further down laterally disappears into zone 1. But I've seen the MRI a little bit more close, and it definitely includes the S1 neuroforamen. This was the, I think it's B3 fracture when you go after AO to talk about the AO.
Thank you.
There you go.
John Hilbert is breathing a sigh of relief.
The German guy. This is the CT that we had from her a couple of years ago, where you already saw that this is going to be a disaster one day, but it didn't. It did hold up again. So what did we do? Honestly, we did something else that what I would have suggested to do from my point of view when seeing these pictures, because I think that this is basically a fracture which includes the lumbopelvic, the lumbosacral junction, and especially because she weighs 130 kilogram, and it is already a lytic process there. I would have probably put some hardware inside. What we actually did was sacroplasty without any hardware. These pictures look weird, but I didn't have a better follow-up examination. There was no post-operative CT done, so this is all I have. Yeah, so I've seen that this woman is about to show up again before Christmas in your clinic, or in Glendale's clinic, I think, because she's not doing good. But I don't have any other radiographs.
Can you go back to the CT scan? So this is a pathologic fracture of the sacrum. It's a B2 injury. John Wyatt, I'm going to exclude Bijan on this one. Fixes now. She's very large. Lumbopelvic fixation, yes, no. We tried a sacroplasty.
Yeah, at this point, you're kind of stuck doing a lumbopelvic fixation surgery. It's just a matter of how many pelvic screws can you get in on the left side, and
3.
whether on the left.
Yeah, 3.
Okay.
If you got 3 in, I want to see it.
Yep.
Wow.
Yev and Jerry will put one in. I'll put the first one in. All right, Andrew, what do you think? I'm crazy, or leave it alone?
No. I mean, you have to fixate it. I'm dying to see how you fixed it.
We haven't yet. I just wanted to have, these 2 cases, I wanted to have opinions.
Do you use washers for that? Looks like it's pretty.
No, I would do lumbopelvic screws. So I would basically do L4 to L5 S1 screws and do a dual rod construct on the left side, like what Thomas Schultar originally described.
No triangular.
Probably not necessary. We'll see. Contralateral single and then dual cross links.
And would you put your screws in the ilium, directly in the ilium, or would you
Modified iliac screws.
It has to be metastatic disease.
Oh, yes, it's most likely, yes. They just didn't get a good sample.
It is a palliative procedure.
Yeah, it is. All right. We've looked at a lot of cases. We've exhausted everybody. Off to a great start for the 7th annual spine trauma course. Thank you all for coming here, spending the late evening here, and your interest, and for industry, your generous support is much appreciated. And our visiting professors, we have an early night, and we'll gather for a little dinner now for a little gathering. Thank you so much.